Every quantitative lab result printed on a report is, technically, incomplete. A potassium of 4.2 mol, or L, was never actually a single, perfectly precise point. It's the center of a real, quantifiable range of values the true concentration could plausibly be, and that range has an official name. That name is measurement uncertainty, a parameter associated with a result that characterizes the spread of values that could reasonably be attributed to the true concentration, genuinely different from error, which describes a specific deviation from a true value nobody actually knows in real time. Confusing the two is a genuinely common mistake. Error is the theoretical, usually unknowable difference between a result and the true value. Uncertainty is the practical, calculable, honest statement of how much confidence you can actually place in that result given everything known about the method. This distinction has genuine clinical teeth. A troponin reported at 52 ing or L against a 50 ing or L decision cutoff looks unambiguous on paper. But if that method's uncertainty spans several ing or L in either direction, the true concentration could plausibly sit below the cutoff entirely. A meaningfully different clinical picture. This is exactly why measurement uncertainty isn't optional paperwork. It's a mandatory requirement under ISO 15189, the international accreditation standard every medical laboratory operates under, which explicitly requires MU to be calculated, documented, and made available to clinicians on request for every quantitative test. Here's a genuinely underappreciated fact. Every single quantitative result your laboratory has ever reported already carries an uncertainty value, whether or not anyone ever formally calculated and documented it. The only real question is whether that number is known, quantified, and available, or simply invisible. So the goal of everything ahead isn't introducing a new source of error into results that were previously perfect. It's making an honest, already existing property of every measurement finally visible, calculable, and genuinely usable at the bedside. Two genuinely different philosophies exist for calculating measurement uncertainty, and picking the wrong one for a routine clinical lab is exactly how this task turns from a manageable quarterly exercise into an impossible burden nobody ever actually completes. The bottom-up approach, formalized in the GUM, the Guide to the Expression of Uncertainty in Measurement, was originally built for calibration and metrology institutes. It itemizes every conceivable individual source of error in a measurement process separately, from pipette tolerance to calibrator uncertainty to temperature drift. For a routine clinical lab running dozens of analytes on multiple platforms, that itemization becomes genuinely impractical fast. Identifying, quantifying, and documenting every individual uncertainty component for every single test is an enormous undertaking few laboratories have the resources to sustain. The practical alternative, the top-down approach, sidesteps that entire itemization problem by using data the laboratory already routinely collects. Long-term internal QC imprecision data and external quality assessment bias data combined into a single, defensible uncertainty estimate without reinventing the wheel. This is precisely why CLSI EP29, the guideline most clinical laboratories actually follow for this task, formally endorses the top-down approach as fit for purpose in routine practice, not as a lesser shortcut, but as the methodologically appropriate choice for the setting. The two approaches, side by side, trade off in an entirely predictable way. Bottom-up buys granular insight into exactly which step contributes the most uncertainty at a steep practical cost. Top-down buys a fast, defensible, ISO-compliant estimate using data that already exists on every QC chart. For essentially every routine clinical biochemistry analyte, the top-down approach is exactly the right tool for the job, which is exactly what we're going to build, step by step, using nothing more exotic than the QC and EQA data already sitting in your laboratory's records. The top-down calculation rests on exactly two building blocks. The long-term imprecision your own instrument has demonstrated on internal QC material, and the bias your method carries relative to its peer group or a reference method, as revealed through external quality assessment. The first building block, U_W, comes directly off your Levy-Jennings chart. The long-term standard deviation of QC results over at least 6 months to a year, capturing real day-to-day, calibration to calibration, and reagent lot to lot variation. not just a single tight runs imprecision. The second building block, U_bias, comes from comparing your laboratory's own long-term mean against an external anchor, typically the peer group mean from an EQA scheme, or, when available, a certified reference materials assigned value, converted into a standard uncertainty rather than left as a raw percentage. A full worked example, 12 months of internal QC gives a long-term CV of 3%, meaning U_W equals 3%. EQA data across the same period shows this lab averaging 2% above the peer group consensus, giving U_bias equals 2. Combined using root sum of squares, not simple addition. That root sum of squares step is worth pausing on, because it's a genuinely common source of error. Square root 3.0 superscript 2 plus 2.0 superscript 2 equals square root 13, which is approximately 3.6%, meaningfully smaller than simply adding 3% and 2% together to get 5%, since independent random sources of uncertainty don't stack linearly. Both components deserve a documented minimum data window before they're trusted. CLSI EP29 guidance points toward at least 6 months, ideally 12, of internal QC data and a minimum of several EQA cycles before either U_W or U_bias is considered a stable, defensible estimate. 2 numbers off data you already have, combined with one specific formula. That's the entire practical calculation. And it's exactly the kind of arithmetic every laboratory already has the raw material to perform without commissioning a single new study. The combined standard uncertainty we just calculated, 3.6%, isn't actually the number you report to a clinician. It needs one more step, multiplying by a coverage factor, to turn it into a genuinely useful confidence interval around the result. A coverage factor of K equals 2. Assuming the combined uncertainty follows a roughly normal distribution, produces an interval capturing approximately 95% of the plausible true values, the overwhelmingly standard convention across clinical laboratory measurement uncertainty reporting worldwide. Applying that to our worked example, expanded uncertainty U equals 2 times 3.6%, which comes out to approximately 7.2%. Meaning a reported result of 100 milligrams or DL actually represents a range of roughly 93 to 107 milligrams or DL at approximately 95% confidence, not a single precise point. Different coverage factors serve genuinely different purposes. K equals 1 gives roughly 68% confidence, appropriate for internal method comparison work. K equals 2 gives the clinically standard 95%, and K equals 3, giving roughly 99.7%, gets reserved for situations demanding an unusually conservative margin. This entire K equals 2 convention rests on one assumption worth stating explicitly, that the combined uncertainty distribution is approximately normal, a reasonable assumption for most routine chemistry analytes, but one that can break down for skewed, low concentration, or near detection limit measurements. None of this needs to be recalculated by hand at the bench, either. Most modern laboratory information systems and dedicated MU calculation tools automate the entire pipeline once U_W and U_bias are entered, turning what looks like a formula-heavy exercise into a quarterly data entry task. A single coverage factor multiplication is all that separates a raw combined uncertainty from a clinically interpretable range. Simple math, but it's exactly the step that turns an abstract statistical exercise into a number a clinician can actually act on. Let's return to the troponin scenario from the opening chapter and work it through properly. A result of 52 ing or L against a 99th percentile cutoff of 50 ing or L with a method-specific expanded uncertainty of roughly 15% at this concentration. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. 15% of 52 ing or L is roughly 7.8 ing or L, meaning the true concentration plausibly sits anywhere from about 44 to 60 ing or L at 95% confidence, a range that clearly straddles the 50 ing or L cutoff rather than sitting cleanly above it. This doesn't mean the result should be dismissed or ignored. It means the single number alone was never sufficient grounds for a confident rule and decision, and exactly why serial troponin measurements, trending over time, remain the actual clinical standard rather than any single value in isolation. This exact logic applies well beyond cardiac markers. Any analyte with a hard clinical decision threshold, a drug level, a tumor marker, a diagnostic cutoff for a metabolic condition, carries the identical obligation to ask whether a borderline results uncertainty range actually clears that threshold. For labs that report uncertainty alongside borderline results, or make it readily available on request, this transforms an implicit clinical judgment call into an explicit, quantified one. Precisely what ISO 15189 intends when it requires MU to be available to the clinicians actually using these numbers. None of this is theoretical hand-wringing about statistics. It's the precise, quantified justification behind a clinical instinct experience clinicians already have about borderline results, now backed by a documented, defensible number instead of an unstated gut feeling. A single borderline number, properly framed by its own uncertainty, tells a fuller and more honest story than the bare digit ever could, and that reframing is exactly the practical payoff every step of this calculation has been building toward. A second, closely related application deserves equal attention. Comparing two sequential results from the same patient and asking whether the difference represents a genuine biological change, or simply falls within the combined noise of analytical and normal biological variation. Notice exactly where analytical uncertainty enters this formula. CVA is the method's own analytical imprecision, essentially the same U_W component already calculated for measurement uncertainty, meaning every RCV calculation is directly built on top of the exact groundwork covered earlier in this video. A worked patient example ties it together. A potassium method with CVA of 3% and a published within subject biological CV of 5% for potassium gives an RCV of 1.414 by 1.96 times square root 9 plus 25, which works out to roughly 19%, meaning two sequential results need to differ by at least that much to be called a real change. Applied to a real patient, a potassium of 4.0 mol or L followed by a repeat of 4.6 mol or L represents a 15% change, below the 19% RCV threshold, meaning that difference plausibly reflects ordinary analytical and biological noise rather than a genuine physiological shift worth acting on. This is precisely why chasing every small serial fluctuation in a stable outpatient's electrolytes is genuinely unnecessary clinical noise chasing. The RCV gives a documented, defensible line between a change worth a phone call and a change that's simply the expected texture of repeat testing. Biological variation databases, compiled and maintained across decades of published research, supply the CVI values this entire calculation depends on, meaning RCV, exactly like measurement uncertainty itself, is never a number pulled from thin air, but one grounded in documented, citable data. Measurement uncertainty tells you how much to trust a single result. RCV, built directly on the same analytical imprecision data, tells you how much a second result actually has to move before you believe something real has changed. Two applications, one shared foundation. None of the calculations covered so far are optional academic exercises. ISO 15189 formally requires an accredited medical laboratory to define performance requirements for measurement uncertainty, calculate it for every quantitative examination, and review those calculations on a defined schedule. A realistic quarterly implementation workflow looks like this. Pull the latest long-term QC data for U_W. Pull the latest EQA cycle results for U_bias. Run the combination formula, apply the coverage factor, and document the updated expanded uncertainty against each analyte's defined performance requirement. Performance requirements themselves shouldn't be invented arbitrarily. They're typically anchored to the analyte's allowable total error, a biological variation derived goal, or a state-of-the-art performance specification, giving each analyte's uncertainty target a defensible, guideline-referenced basis rather than a round number picked by convenience. A typical implementation timeline, start to finish, runs across a full accreditation cycle rather than a single afternoon. Initial data gathering, first calculation and internal review, comparison against performance requirements, and then ongoing quarterly to annual recalculation as new QC and EQA data accumulates. A common early implementation stumbling block worth flagging directly. Treating measurement uncertainty as a one-time compliance checkbox rather than a living calculation that should shift as reagent lots change, instruments age, or a method undergoes a documented recalibration. Analyzer and LIS vendors increasingly build this entire pipeline directly into their software, automatically pulling QC and EQA data and recalculating expanded uncertainty on a set schedule, meaningfully lowering the ongoing labor burden compared to a fully manual spreadsheet-based process. From a mandatory accreditation line item to a quarterly data entry routine, that's the realistic distance between where measurement uncertainty starts as a requirement and where it ends up as genuinely sustainable laboratory practice. Everything covered across this deep dive traces back to a specific, coherent set of documents rather than scattered convention. The GUM for the theoretical foundation, CLSI EP29 for the practical clinical lab pathway, and ISO 15189 for the accreditation requirement, tying it all together, laid out end to end. The entire discipline resolves into a single clean chain. Long-term QC and EQA data feed the top-down calculation. The calculation produces a combined and then expanded uncertainty. That expanded uncertainty informs both cutoff interpretation and RCV thresholds, and ISO 15189 requires the whole chain be documented. For any technologist starting this from scratch, the realistic entry point is refreshingly narrow. Confirm at least 6 months of long-term QC data exists. Confirm recent EQA cycles are on file. And the 2 core building blocks for a first calculation are almost certainly already sitting in your laboratory's own records. The scale of what this quietly protects deserves one final number. Every quantitative result on every report, across every accredited laboratory following this exact framework, now carries a documented, defensible confidence range instead of a bare digit standing entirely alone. None of this replaces clinical judgment. Either, it sharpens it, converting a vague sense that borderline results need caution into a specific, calculated range a clinician can weigh directly against a decision threshold, backed by data the laboratory can defend on request. Looking ahead, the frontier here mirrors what's already happening across laboratory informatics broadly. Increasing automation pulling QC and EQA data directly into uncertainty calculations in real time, moving this from a quarterly manual task toward a continuously updated, always current property of every result. A bare number was never the whole truth about a result. Measurement uncertainty is simply the honest, calculable, guideline required admission of exactly how much confidence that number actually deserves, and now the full mechanism behind stating it correctly. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.